what is called state-of-the-art prostate SBRT on a MRI linear accelerator. So what are my disclosures? Well, I'm a radiation oncologist. For better or for worse, what pays my mortgage payment is treating men with prostate cancer with radiation. Although above and beyond that, I have no relevant disclosures for this topic. So there's three things I wanted to talk about. So I can't really talk about the MRI linear accelerator without talking about how far we have come in the treatment of prostate cancer over the decades. A lot of how far we have come is based off of technological advancements, so it's worth highlighting some of those and spending 10 minutes to understand where we've come from to get here. And then finally, I wanted to talk about the MRI-Linac, MRI Linear Accelerator, and also show you some cool videos about why we're excited about this technology. For many decades, I think it surprises a lot of patients to hear that external beam radiation has really been a mainstay of treatment, even if you go back in history, even before surgical removal of the prostate, radical prostatectomy. To understand why that is, you also have to understand that prostate cancer was actually a very different disease dating back 100+ years from now. Does anyone have an idea of when PSA first came to be a mark could be used?
1950s.
It was first developed in a lab in 1970. It did not enter clinical practice until the early 1980s. I think it was approved by the FDA in 1980. So can you imagine, like for me, this would be, to be fair, this is how we deal with about 90% of other cancers, but without a PSA blood test, that influences our management of prostate cancer in so many ways. It's just amazing to think about what life would have been like before that. In the situation without PSA screening and PSA to help risk stratify men, a lot of men would present with urinary obstruction. They would present with stage 4 metastatic prostate cancer with painful bone metastases. So the idea of surgery was really not entertained because it was really seen as a very aggressive disease at the time. So we didn't have CT scans, we didn't have MRIs, we talked about PSA. Surgeons had been trying to do surgery. The first documented prostate removal surgery was in 1904. For those who know what the word transperineal means, what that means is removing the prostate from that patch of skin between the scrotum and the rectum, so sort of taking it out from below. And then the first sort of, quote, modern retropubic prostatectomy, meaning doing an open incision in the belly and then dissecting out the prostate, was done in 1945. If you look back on a lot of the scientific literature from that time, it was really described as a futile and morbid procedure, and only for the earliest of cancers, keeping in mind at the time, we could not detect the earliest of cancers because we didn't have PSA. Not coincidentally, surgeons got a lot better about doing surgery in the 1980s. And if you remember the timing of PSA screening, detecting men with earlier cancers, surgeons are very ingenuitive, and the modern so-called nerve-sparing prostatectomy technique, which is now standard, if maybe not for some surgeons even as recently as 10 years ago, but still the nerve-sparing prostatectomy came in 1983. And then for what's near and dear to my heart, prostate brachytherapy really, also dates back to these early, sort of futile attempts, not really knowing what we're doing. And really modern brachytherapy, as we use now, sort of dates back to the early 1990s. So we know that radiation therapy kills cancer cells by causing DNA damage to cancer cells. And a lot of this dates back to discovery of the X-ray in 1895. But it was soon discovered soon afterwards that you could actually have biologic normal impacts above and beyond just looking at a bone. How radiation technologists used to calibrate their X-ray machines is they would hold their hand in front of the X-ray until you get a little bit of pinkness on the skin. And then that's how they would know things would be set up properly. And then you would have discovery of that these X-rays could actually treat superficial skin cancers. Of note, there are some horrific images of the consequences of using your hand to calibrate an X-ray. And it was not that soon after we realized that there are dangers to radiation as well. So really through the 1900s to 1940s, we could treat superficial cancers with radiation. We didn't really understand how it worked. We didn't understand the concept of preferably breaking it up into multiple smaller treatments. And simply speaking, cancers deeper within the body could not be treated because by the time you got enough radiation down there into the pelvis, someone's skin was toast. So you have these really funny historical apparatuses. So this is not someone with prostate cancer, but this is an early treatment for uterine cancer from the 1930s. And essentially, this was using internal radiation like brachytherapy, trying to get around the limitations with what we had at the time. I obviously wasn't around that. Modern radiation starts around the mid-1950s with the concurrent discovery of what's called megavoltage radiotherapy, as well as cobalt radiation. And on the left here, we have an early Betatron machine that would deliver megavoltage radiation that actually had skin-sparing properties so that you could get a sufficient dose of radiation down to where you would have a target. The issue with a lot of these machines, and very different than what we have now in 2025, is that these machines could not really move in any way. The patient could move a bit, maybe it had a few degrees of angle of change. On the right here, this is a picture of a cobalt radiation treatment machine. Where I trained in London, Ontario was actually the first place that cobalt radiation was used worldwide. Even still, we're very limited in what we can do just because of how accurate can we be with treatment? How do we know that we're hitting the actual target? I put this in here because this is fantastically interesting. This was groundbreaking in 1965. This is a little more than 20 years before I was born. So this is super voltage radiation. Henry Kaplan has written numerous textbooks that even still have his name on them in 2025. So essentially, what would happen in this is that a gentleman with prostate cancer, if you'll notice, this is somewhat similar to the cobalt machine. It was actually a megavoltage machine. The machines couldn't move. Well, what smart radiation doctors would do is if you can't move the machine, you move the patient. So they would stand up for their treatment. Many of you who have gone through radiation know that that doesn't happen now. We all lie down on a treatment machine, and the patient would be rotated around the radiation treatment source. How would you know you're hitting the right target? Yeah. Well, what you would do is you'd combine it with an X-ray, and while I'm not sure, there's a laser pointer. What you'll see here is a Foley catheter with a balloon in the bladder. What you'll also notice behind here is some contrast that's put in the rectum. And then you've got this sort of generic box where you say, well, the Foley balloon's here, so the bottom of the bladder has to be here. Here's the front part of the rectum right here. So the prostate is probably in this box somewhere. So the survival outcomes of patients treated with this was groundbreaking at the time. And it's really, I'm putting this here because the survival outcomes of men that we currently see with newly diagnosed stage 4 prostate cancer actually look as good or a little better than this. But this is including some patients with localized prostate cancer. And at 5 years after treatment, less than 60% of men were just alive. These are drastically different treatment outcomes from what we see now. So this is called a 2D simulator or a plain film simulator. I am young enough that I never had to use this. Does anyone recognize this? Ottawa had one of these, I think, as recently as about 15 years ago. It looks somewhat similar to some of our technology, except that we did not use CT scans to design and plan radiation. We would use X-rays. So I did my best to try and unearth some old records from prostate radiation then. I unfortunately could not get my hands on some records. But here are some other examples. So up here in the top right, this is someone treated for a lung cancer. You see the radiation port film here in this square. This is radiation from a head and neck cancer. So there would be some drawings of where your target is. And this is the area that you're treating. Radiation treatments for lymphoma would often involve irradiation of the mediastinum and lymph nodes. Still, we are getting better. We can use bony anatomy to correlate findings on CT scans at the time, but it's still not very accurate. This is the era that I grew up and I trained in. For what it's worth, this is what is modern and standard pretty much everywhere in Canada. So on the left, we have what's called a CT simulator, slightly different than a diagnostic CT scan, but the nuances are not incredibly important. What really matters, though, is that with a CT scan, we can design treatment based on a target. We also have the ability to control the radiation dose using a modern linear accelerator. And a linear accelerator has a few very unique features that are critical. So there is, first of all, no radioactive source inside of these machines. But from the head of the treatment machine, you have this beam of radiation that can be sculpted in size, sculpted in intensity, and also you can treat the cancer from many different angles as the machine is moving around a patient. So you can get these great radiation treatment plans that sort of allow radiation dose to spill out into areas that are not as critical in causing side effects. This has been standard in Ottawa for quite some time. I think of all the things we've talked about with technical advancements. Does anyone know what this is, by the way? Someone must know this. Someone.
For scanning for your teeth and all that.
Yeah, this is a Panorex X-ray that some of us have probably had the pleasure of going to our dentist for. I would argue this technology has been the most groundbreaking technology, other than maybe the MR-Linac I'll talk about, in modern radiation treatments. Why is that? Every radiation treatment machine now has one of these cone beam CT scans in order to make sure we're hitting the target before each treatment. So to show you briefly here, this big part of the head that says variant here, that's where the radiation comes out of. But these other two arms on either side allow us to do a miniature or cone beam CT scan before each radiation treatment to make sure that what we've designed is actually what we're delivering with the standard treatment machine. So on the left here, we have a radiation treatment plan and targets generated for a gentleman with prostate cancer. The prostate is in yellow, seminal vesicles are here in orange, bladder is in blue, rectum is in red. My OCD personality does not understand why the bladder is not yellow, but that is besides the point. So on the right here, we have a cone beam CT image. This is probably a better cone beam CT than at most radiation treatment centers, but you can see things line up really well with that. And you can be sure that at the beginning of treatment, before you hit the on button with the radiation, that you're hitting the right target. I went back in some of my records. Our cone beam CTs here in Ottawa aren't quite that good, but we can pretty reasonably see, okay, well, where the rectum was at the original scan is still here in brown. Here's our target for treating the prostate. We can see that things line up pretty well there. So I think I got the order mixed up a little bit here, but anyways, we'll move on a little bit from here. So cone beam CT, really important ability to treat the prostate accurately. Historically, before my era of treating men with prostate cancer, it wouldn't be uncommon for men to undergo 7 to 9 weeks of daily radiation treatments. And it was felt that it was safest to give the radiation in sort of bite-sized small amounts each day. And we've had many years of clinical trials to guide us that that is sort of flawed thinking when it comes to prostate cancer. So this, the first major study was actually run out of Princess Margaret. 1,200 men with prostate cancer were treated either with 39 treatments, almost 8 weeks of radiation in comparison to 20 treatments or 4 weeks of external beam radiation. Cure rates were identical. No increase in toxicity with making treatment more important. And actually, there was less bowel toxicity in those treated with 20 treatments. The next step moving forward is the era moving to prostate SBRT. And by SBRT, what we're referring to is highly precise, highly conformal radiation delivered in a minimal number of treatments. For reasons that I can probably talk your head off about, 5 treatments has sort of become the sort of threshold or cutoff for what's considered SBRT, although that's not the only number of treatments that we can use. But in increasing the dose for treatment, there's a few challenges you have to consider. So one thing that patients often think about is, oh, well, I'm getting more dose, it must be a much longer treatment. That's actually not necessarily the case. We have technological advances that actually the beam on time is not dramatically different. But where we become concerned is that now that we're using an incredibly high dose of radiation for each treatment, are we actually hitting the target? In addition to that, because of the the bowel and the bladder that is nearby, we really want to make sure that we're using tight safety margins to keep high doses of radiation off of those structures. One way that we do that with standard prostate SBRT is actually mandating patients doing a fleet enema before each treatment. I apologize, it sucks, but that is something that allows us to be more accurate with treatment. The real issue with why prostate SBRT has not taken off, at least around North America, is this issue with something called fiducial markers. So what fiducial markers are these little tiny implanted seeds within a prostate that are not radioactive, but what they allow you to do is to be extremely precise and accurate with where the prostate is located to make sure that you are hitting the target for treatment. This is what was necessary for doing prostate SBRT on the CyberKnife. Why the CyberKnife was so influential and new is that it had live imaging of these fiducial markers throughout the entire course of treatment. I don't like fiducial markers. It only takes your first patient who has them put in and then ends up in a merge, septic, admitted to hospital on intravenous antibiotics at home for weeks before you recognize that this is not a benign procedure. As we've reflected upon this as a group here in Ottawa, it probably reflects mostly the fact that the way that these have historically been put in is transrectally, the same way as a common biopsy. Most men have recently had a transrectal ultrasound-guided biopsy, so they've been exposed to the same antibiotics. And the infection rates that we were seeing with putting in fiducial markers were still in the single digits, but they were much higher than we were really comfortable with. In my training before coming to Ottawa, I would put in these fiducial markers transperineally through the skin, which is fine to do. The issue is that we don't have the staffing for me to put in 300 or so sets of these fiducial markers for all men with prostate cancer getting radiation here in Ottawa. Prostate SBRT with fiducials is an excellent treatment. So we've had a randomized trial that has compared 20 treatments to 5 treatments. This figure is a little bit different than the last one I showed you that compared 39 treatments to 20, because in this study, they did not include failure as a man dying from other causes. So the cure rate at 6 years is 95%. Excellent with SBRT. Similar even with 20 fractions though. And numerically, I don't think that there's a big difference between 95.8% and 20 fractions at 94.6%. So what I would counsel my patients is that we have 2 options. We can do 5 treatments. Needs the fiducial marker insertion. Have to tell your patients about the risks of that. Or we can do 20 treatments. The bonus is you don't have to do 20 fleet enemas. And a lot of patients would say, look, you're telling me this SBRT is not any better. I live 10 minutes from the cancer center. I'll go for 20 treatments. Prostate SBRT in this clinical trial did not show any differences in long-term toxicity, either from a bowel or bladder perspective, either as it was assessed by physicians, or I think more importantly, when patients fill out quality of life questionnaires. There was a trend to maybe some less sexual dysfunction with prostate SBRT, although, once again, is that a clinically meaningful difference to choose one versus the other? I actually don't think so. So essentially in 2024, this is last year, I have a lot of tools to offer my patients who want radiation for their prostate cancer. This isn't even including all of the wonderful surgical options, and it's also not including what I think is the preferred option, which is active surveillance when it's safe and reasonable to do so. So 20 fractions of external beam, long held standard for over 10 years. This is also how we treat pelvic lymph nodes for gentlemen who have high-risk prostate cancers for high risk of spread to the lymph nodes. 5-fraction prostate SBRT. We had some enthusiasm, but the main issue was the fiducials and the risks associated with that. Of note, for men who have high-risk prostate cancer, we actually have a clinical trial ongoing that is randomly comparing 20 treatments to 5 treatments, including treatment of the pelvic lymph nodes. Much more convenient for patients. It does require fiducials to be put in. And this is, of course, not to mention what's near and dear to my heart with prostate brachytherapy, which I told myself I wouldn't talk to you guys too much about tonight. So really, where we've had a shift in how we practice is the MRI-Linac. So here is the standard treatment machine that I showed you. We've talked about how the treatment is delivered. We've talked about the critical cone beam CT. Here is a MRI-Linear Accelerator. This is the stock image. I do have one that we have here in Ottawa, but essentially it looks very similar. As you will notice, it can be quite claustrophobic. So a gentleman will go in head first into this machine. It is similar to a wide bore MRI, but it can be incredibly claustrophobic. You don't have any sort of wiggle room around you. Luckily, I think we now have a Spotify account to listen to some nice music during the time of treatment, but things look very different in a lot of ways here. What's the main advantage of this machine? The main advantage is using the MRI before and during each radiation treatment, in addition to using the MRI for each radiation treatment and customizing the radiation treatment each day. The radiation beam that we use to actually treat the cancer is not significantly different from a standard machine. So the radiation beam energy is not dramatically different. The characteristics of the radiation beam are not significantly different. So really the benefit comes to adapting the treatment to the anatomy of the day. And if I were to go back, I'll just go back a whole bunch of slides here really quickly. So when I was talking about these cone beam CTs, we would make sure that we're treating the target, that we're still in the same place, but we're not actually changing the radiation treatment. So if you're getting 20 radiation treatments, it is the same radiation dose to roughly the same target, but the treatment is not actually adapted or changed for those 20 treatments. So the real benefit to the MRI-Linac is that we're able to adapt the treatment as we go. So currently there's 9 MR-Linacs across Canada. The newest one is here in Ottawa. Princess Margaret and Sunnybrook have actually had them now for about 5 years. So it's not a brand new technology to Canada. Our colleagues in Alberta have 3 of them. Anecdotally, I just got back from the Canadian Radiation Oncology Conference in Calgary, and my colleagues who work in Calgary say that these machines are really not being used all that much because of the extra pressures they're facing in terms of health human resources and wait times in Alberta. I'll talk about that in a second in terms of what the extra work involved in doing this is. And there's 2 of these in Quebec that are online or going online shortly. The first patient who was treated was only on June 10th of this year. So this is pretty, hot off the press. And so far, we've treated 26 patients who've either completed or on treatment right now. 2 of them here. Yeah. Wonderful. And we have at least 9 more in the booking queue to look at starting and plan to be started as soon as we have availability on the treatment machine. The workflow is somewhat similar. We still need to design a radiation plan before we do the first actual treatment. Right now, patients actually have to come for quite a long day where we do a standard CT-based simulation. Why we still need a CT scan as part of this process actually has a lot to do with technical complexities of how radiation is delivered, but to put it very simply, how radiation is absorbed in bone is very different than how radiation is absorbed in air or water. And there are some subtle differences that we take into account by using information from the CT scan. Starting out, we weren't sure of the image quality on the MRI-Linac, so we also did a standard MRI on fraction 1 on our sort of diagnostic quality MRI. I think we're going to be looking at just doing a CT and an MRI simulation on the MRI-Linac and removing the second MR from the process. Because there's patients who, they're waiting for MRIs for radiation treatment planning, where I don't think this is a very high yield for having patients come for 2 MRIs. Here's a quick tour of the machine. It actually is in bunker 11, which is where the CyberKnife used to be. We've actually moved the CyberKnife to a different area. We have a new CyberKnife. This is a picture of our MRI-Linac, very similar. They're standard all across the world where they are used. Some differences with this machine are that when a patient is inside of the machine, it can be claustrophobic. The treatment bed cannot move or adjust nearly as much as a standard linear accelerator. So I'm not sure that we'll ever be able to get the CT out of this, because lining patients up correctly is actually a really critical aspect that we're actually using information for the CT to actually use right now. Now, this is a picture I wanted to make sure no patient was in here, but this is what we see during a treatment. So we can see you on the treatment machine, we see the room. To make sure that we're in constant communication with our patients, we have the ability to do voice communication. Admittedly, because of the noise of the MRI, it can be really difficult to hear patients through this. Treatments are done twice a week. The days of the week are not static. The reason for this is that in order to make this treatment work, you actually need a radiation oncologist such as myself to be there to design and customize each radiation treatment. So from a workload point of view, this has really increased the amount of work for our radiation oncologists treating prostate cancer. We all think it is worth it, so we're willing to put in the extra time. But for example, I spent all day today on the MRI linear accelerator. Like, I had meetings at 8 o'clock in the morning. I was down at the MRI linear accelerator between 9 and 4 today, treating patients on this machine. But part of the functional limitations of this is that there's only so much time to go around. I actually had to cancel a patient clinic over at the Irving Greenberg this morning in order to make this work, because none of my other colleagues were available for me to be there today. There is certainly hope and plans that we will not physically need to be there on the machine. And ideally, this would be nice that I can do this. I would love for this to be that I can do this from my office at the Irving Greenberg while a patient is on the machine here at the General Hospital. There's lots of technical limitations with that we're working on with that. So the workflow is, the treatment is quite a bit longer. So I suspect that some of you have undergone standard external beam radiation. Practically speaking, a patient is usually inside of a standard treatment bunker for a standard treatment with prostate radiation for about 15 minutes or so. Sometimes even less when it's a well-oiled machine. The radiation machine is on for about 7 or 8 minutes. For this, we schedule one patient for every 1 hour and 15 minutes. We can probably get that down a little bit if things go smoothly, but there is the positioning of a patient on the bed for the treatment. We acquire an initial MRI in order to design a plan of the day. We then do a verification MRI image to make sure that things have not moved in that plan generation phase. It probably takes only about 15 minutes to generate a plan from scratch, which is really groundbreaking in itself. Like, generating radiation treatment plans used to take days. So with the technology there, we can get that done in 15 minutes and customize it. And then in addition, once we're sure that the verification images after the plan has been generated are matching up, we have live MRI images through treatment. So this is what a radiation treatment plan looks like on an MRI linear accelerator. What we can see is that we're able to get very high doses into the cancer, into the prostate, and then we still are able to sculpt the radiation dose as much as possible within the limitations of our radiation beam energy away from the rectum and the bowel. And essentially, this is all done using MRI images. And one thing I didn't get into, but drawing and identifying where a prostate is located is fundamentally very difficult on a CT scan. And there's some good data that using an MRI for radiation treatment planning itself, even if you're using an older treatment machine, actually will lead to less toxicity. So the real crux of the question is, is this better? What are we changing? Is this actually groundbreaking for patients? So the actual radiation treatment beam is similar to a standard Linac. The real benefits of this is both the customization of the treatment plan depending on the anatomy of the day. You would not believe how small differences in bladder filling and rectal filling can actually have a substantial difference in the radiation dose that those structures receive. But the real benefit is the live imaging of whatever organ you're treating, in this case, the prostate, during treatment. So if I have done my technology and pretended like I am actually technologically savvy, so these are some live images of patients getting treatment during the MRI-Linear Accelerator. So what you'll see here in green is actually the volume that we use as sort of encompassing the safety margin to make sure that we're not missing the target. What you see in this video is you actually see, see if it'll go again. That's okay, I've got a few of them here. So what you'll actually see is you can actually see some bowel motion here. Anyone who has been with me in a prostate brachytherapy ultrasound before brachytherapy, there will be a time where I tell you, okay, time for the jokes to stop because you're moving your prostate too much by laughing. But taking a breath, you can see the abdomen moving in and out or taking a breath. We can make sure that the bladder is staying adequately full, the target is on. But critically, the most important thing is we can make sure that there's no big bubble of gas coming down into the rectum and pushing the rectum right into our high dose of radiation. So here's another patient. The angle, this is my first attempt, the angle's a little bit off. But once again, you actually have this live image all the way through each radiation treatment. The treatments are a little bit longer when the beam is on. It's closer to about 12 to 15 minutes with the beam actually on, but you have this live image. Now, what's really nice is that we can see situations like this. So what we see here in black is air. You have situations like this where this bubble of gas has actually pushed the prostate forward, and you now see this safety margin is actually within the rectum. So we do have a video of this. Unfortunately, when I was doing this, the staff were watching it. I didn't have my camera rolling the whole time. But what we have is the beam was actually paused during this time point. And while I'm filming this, that's one of our radiation therapists who's pointing out what we're doing there. What do we do in this situation? Well, quite simply, we wait because this bubble of gas is going to move. We have a live image of the patient, so we will often say, okay, do you feel like there might be something to come out there? So often this bubble of gas will pass. Even towards the end of the video, you'll see that actually the prostate is moving back into the position for this. For this patient, we were able to resume the rest of the treatment, but pause it in that critical moment when the rectum was pushed into the beam of the radiation. So I think this is really where the crux and the benefit of this lies. Do we have data to back this up? So it's all great. Many of you may have questions from patients or colleagues about things like proton radiation and things that sound a lot better on paper. But really what matters is whether we have data to back this up. So there actually is a randomized controlled trial that has been completed. This was presented last fall. It's since been published, but I just reused my slides from the American conference that I went to and brought back information from here in Ottawa. So this is a clinical trial of 150 patients that were randomly assigned to either get MRI-Linac treatment versus standard prostate SBRT. So all patients got the same dose of radiation. They have already reported the short-term toxicity data that actually shows that there is less short-term bowel and GU is genitourinary or bladder toxicity with the MRI-Linac. There's a key but here. So what the group at UCLA did is they actually reduced the safety margin because of the online images during treatment, because they were more confident that they were actually hitting the target. So it's not really an apples to apples comparison, just purely of the technology. It is a comparison of a standard treatment with prostate SBRT versus where we hope to get with the MR-Linac by actually shrinking that safety margin. In terms of long-term toxicity, so these short-term changes do persist in terms of long-term better bowel and urinary quality of life. This also, so these are the proportion of patients that have a big change in their bowel quality of life, statistically significant improvement there. And then looking at patient-reported outcomes, they didn't have really nice slides for this, but essentially there was a patient-reported improvement in bowel function as well as also sexual function. This is a separate clinical trial to what I've mentioned before, but there do seem to be some long-term differences in this clinical trial. So from my point of view, this is why I'm really trying to push through this concept of what's called margin reduction. Because I'm not sure how much of this is due to just watching the prostate during treatment versus actually shrinking our safety margin by another 2 millimeters. 2 millimeters isn't very much. I brought a ruler out here. Doesn't sound like much, but I think that's actually where we're seeing the difference. Currently, with the technology within our MRI-Linac, doesn't allow us for this aggressive PTB margin reduction that's described in this trial. In this Mirage clinical trial, they had a Meridian MRI linear accelerator. They were sort of the competing MRI-Linac to the Elekta one that we have. Unfortunately, ViewRay is in the process of bankruptcy receivership, and last I've heard, these machines are sitting idle because they can't actually treat patients with them right now. So I know they're trying to revamp those, but still, it's an unfortunate consequence of the business model of radiation oncology in the US. There are no Meridian machines in Canada, and one of the reasons why we chose this Elekta machine, knowing that at the beginning of we couldn't do this margin reduction, is that Elekta is one of the biggest producers of radiation technology in the world. We know they're not going to go under. We know our machine is not going to be collecting dust. So personally, I think this is great new technology that allows more confidence that we're hitting the target. I think that this provides a more convenient treatment option. So if I think of what I was counseling patients on last year, I think prostate SBRT is great, but I think that there are some nuances to it that are less than ideal. I think that in a patient who hears about some of the technological benefits of this, the fact that it's only 5 treatments instead of coming for 20, I think this is a great option that we have available. I would tell all of my patients, though, is that based on the data that we have, SBRT is not necessarily a more effective treatment than 20 fractions. I'm not expecting this to provide a better cure rate for patients in comparison to those who are getting 20 fractions. I think that by making sure that we are hitting the target, we may decrease some element of toxicity. Because if you go back to that video where that rectum was inside the radiation treatment field, even if we don't like to say it out loud, we know that this would happen with older technology. We just couldn't see it because we weren't imaging through treatment. I think anyone who has seen me outside of this building and has had to see me in a hospital situation, I truly believe that there is no one-size-fits-all solution when it comes to men with newly diagnosed prostate cancer. Certainly when it comes to some of the other data for prostate SBRT, men who have very enlarged prostates, men who have a lot of baseline peeing problems, they may be better off with the slightly more gentle dose per treatment in 20 fractions. That is not a hill that I'm willing to die on. But if someone is willing to entertain surgery, someone with an enlarged prostate, a lot of obstructive urinary issues, I often say surgery is actually a very reasonable option if you're willing to deal with a lot of the other potential consequences of surgery. Some men are really enthusiastic about this and they've heard about it. They know someone who's gone through treatment, but they're not eligible for it. So there are some key exclusion criteria. If you can't have an MRI, I can't stick you inside of an MRI machine. We can't have someone with a pacemaker because of the technical complexities with the pacemakers and the safety of that. Those who are claustrophobic, we often will steer away from that. Anecdotally, I had my first patient who told me that he would be fine and then saw the machine and said, no, 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 no. So what we did for him is we actually turned him around and put him feet first into the machine, which from a technical point of view, the machine doesn't care about. When we're treating prostate cancer, it's not like we have to worry about mixing up right side and left side. We're treating the whole prostate. And he also needed a little bit of Ativan to get him through his treatment, but still he was able to get through his 5 treatments. I think of the 26 patients, he's the only one that's had to go in feet first. To be fair, I'm asking my patient, how did you do with your MRI issues with claustrophobia? Because it is a tight space. Now, if I go back to, oh, sorry, I'm going the wrong way. Oh, no. I went the wrong way.
So feet first, your head's not in there?
Your head will, yeah, your head will be outside. Your head is outside or just outside of the machine, even if you go in head first. When you are inside the machine, your head going in head first, there is sort of an opening on the far side of the machine. So if you just sort of tilt your head up, you can sort of see outside of it. It's not like it's a hard wall, but it is claustrophobic. I mean, certainly we've got some firsthand experiences here to describe it better than I can. I have never laid down inside of the machine. The front of the machine is right there.
So more claustrophobic than a regular MRI machine, is what you're saying?
No, not dramatically different than that.
Oh, okay.
For those who did hip replacements, is that disqualify them?
Yes, so that's what I was gonna get into in a second. So if we look here at yeah, so here is the top of the machine here. So patients will go in and slide in this way through the bore. This is the other end of the tube. So how tall you are does have some impact on this. But even still, your head is also not gonna be right out here either. But you don't have that sense of sort of having something right above the top of your head. There is no doubt it's claustrophobic. And for some people, this is just an absolute no-go. We can put them in feet first, though.
So we're like, watch a movie.
Yes. Well, this is a little quicker than that too. Although, admittedly, though, we don't have a video machine for this. Apparently, that was an extra that cost too much money. Hip replacements. So essentially, the metallic artifact from an artificial hip, in addition to the inability to use certain angles, makes it so that we cannot do MRI linear accelerator treatment for someone who has even a single hip replacement. There's of course other patients who can't undergo an MRI. They have shrapnel, they've got something metal in their eye that they know about. All sorts of weird and wonderful things that come up. The other thing too is that we're treating only prostate-directed radiation. So there are many situations where, based off of risk category and risk of spread to pelvic lymph nodes, where there is a benefit of giving prophylactic or preventive radiation to pelvic lymph nodes. Similar to the CyberKnife, we can't treat the lymph nodes with this machine. So if someone has a very high risk, very aggressive prostate cancer, even if it doesn't look like it's spread to pelvic lymph nodes, this may not be the best treatment. I've heard from some of my colleagues they're experimenting with it. It would take a lot longer to do a treatment with incorporating treatment of the pelvic lymph nodes in it as well. I think the key thing is that this is good for those where external beam radiation is an option for them. I'm not sure this is such a game changer that I'm changing some of the fundamental principles of my counseling. There are many men where I think brachytherapy or prostatectomy should be their treatment option, and that is what I will be honest and tell them. I don't think that this is replacing LDR permanent seed brachytherapy in a patient who's 53 and has a 40-year life year expectancy. I think LDR brachytherapy and radical prostatectomy are the treatments that we have excellent long-term data for and are the default options. Of course, depending on which radiation oncologist and surgeon you see, it's worth keeping in mind that recommendations are not universal amongst even the 8 radiation oncologists that work here. I'll leave it at that, but I can talk your head off about that. But I have to say that when this was published, so these are 2 of our excellent radiation therapists, and this is not a patient, this is actually one of our physics associates who was our dummy patient, where we didn't treat his prostate, but he laid there for the whole course and we planned sort of the dummy for the first treatments, is that this has gotten a lot of attention. Patients are bringing this up to me, even not part of the support group. So when Terry asked me to come here and talk about this, I first tried to pawn it off on my more junior colleagues and no one jumped up to do it. So here I am again, you're stuck with me again. And really, I do think this is an engineering marvel. I think where I wanted to end this is that this machine is good for treating prostate cancer. I think with the investment that we've made in this machine, I think that we are looking at expanding into other types of treatment, particularly with types of treatment that I would call having a more narrow therapeutic window, where there's a lot of really critical structures right nearby what you're trying to treat. Traditionally, we've been scared to dose escalate to radiation doses that we know that can ablate and kill off cancer in a certain area of the body. The sort of holy grail of this, and where I've heard about this for, as long as this technology's been developing, is really in things like pancreatic cancer, where you've got, an aggressive cancer, difficult to resect surgically, but you've got a lot of critical bowel structures nearby that we just can't get the radiation dose into. In times where we're doing re-irradiation in areas that have had previous radiation, and we want to really make sure that we're keeping the radiation off of that loop of bowel that's nearby, but then also watch during the treatment to make sure that bowel's not coming in. Currently, right now, because we're still sort of in the early learning phase, making sure our staff are comfortable, right now it's only prostate SBRT. I think that in the next 3 months, we'll probably start expanding that to some other sites, some of which I'm involved in, some of which I'm not. I think there will be a really interesting philosophical question that if we have other treatment sites that may benefit more than prostate cancer, will we have to start saying, look, we actually can't offer this because we have too many patients with other types of cancer that we think are benefiting more. Currently, right now, that's not a risk. Certainly, there is a lot of my day and it's disrupted our schedule so that it's a lot more work for us to do this. I think the benefit is there, but in a year or 2 years, will this still be what we're doing? I'm not really sure. There was certainly a time we were extremely enthusiastic about CyberKnife prostate SBRT. I think there are some benefits to it if you look at the data, but I'm not sure it's that much of a groundbreaking machine when we have patients with brain metastasis, spread of cancer to the brain, where that machine is really, truly making a consequential difference to their treatment. Hence, I think that in my time here in Ottawa, we've seen the number of patients with prostate cancer being treated on the CyberKnife essentially go to 0. And in my 4 years here, I think I've treated 3 patients on the CyberKnife. And that's it. And that's as someone who's a big believer in prostate SBRT. But if I had to ration resources that we have, I think there's better uses for the machine in that situation. And I don't want someone with a critical life-limiting illness to be waiting when I think there's almost as good treatments otherwise. But once again, that's open to debate. So who knows what will be going on in the future? And I wouldn't be surprised if Terry emails me in a couple of years and say, well, someone just told me this, and I can perhaps provide some rationale from the other side of things. Anyways, that's the end. Kept it under an hour there, but I'm very happy to stick around and answer any questions. And thank you everyone for your attention. It's always a pleasure to come here and talk about things like this.
Thank you for doing this for us. Believe me, this is
No
very
problem,
huge
yeah.
benefit.
Yeah, I think it's helpful, and with the degree of support that you offer our patients, I think it's critical for people here to know about this. Certainly, it was actually my patient who was the first one treated here in Ottawa, and he was very nervous about it. It was new, and you can argue whether we should have done this, but he knew he was the very first patient. He knew he was the 8 a.m. patient, day number 1. I mean, so he knew that he was but still, like, so
That's
very nervous, something, but still, this is something that is evolving and something that we're using. So,
I've got a question, I'll ask it twice once we're ready, but you can
Yeah.
think about the answer. Having gone through 20 sessions of VMAT, the usual routine, how much does the prostate change in the 4 weeks? Does it get bigger, smaller, or does it stay exactly the same?
it
Could you
does
talk
not
about-
stay exactly the same. That's a fantastic question, and I love teaching the resident doctors who work with me about this. So, if we were to put you on this machine, which some people have done, and draw out and customize a treatment every time, you actually do see volumetric growth of the prostate through treatment, both with SBRT, but even with 20 treatments. To me, when I first heard about this, a light sort of went off in my head. So when I am doing brachytherapy, the thought process has been is that it causes peeing issues because you get swelling of the prostate, sort of shish kebab someone's prostate 16 times or whatever is needed to get an ultra high dose in there. But actually, I think a lot of it is actually, you do see that physiologic reaction. And that makes sense. I mean, I hand out tamsulosin and Flomax like candy. Any hint of more
Thank
obstructive
you very
peeing
much.
problems, and I know exactly why it's there. And it's not like tamsulosin is not actually really helping the bladder in any way, but actually I think it's relieving that small degree. Now we're talking about growth that's measured in maybe by the end of treatment 10% at most. Like it's not a huge amount and often much less than that.
But did
But it's
they
enough.
change, would they have changed my treatment plan at all, or is it the same?
With the 20 with VMAT, no.
No.
We accepted a slightly larger safety margin to account for those issues to make sure that we were still hitting the target. So there's no worry about it. Like we've been using 20 fractions of
Yeah.
VMAT for a long time. We know it works really, really well. This is just trying to make it that little bit better. Excellent question.
My question is proton treatments safer, and is it more effective than the MR-Linac treatment?
Great question. So this has been an ongoing debate and question for decades. So actually, proton treatment for prostate cancer is actually a really old treatment. Modern proton machines are better, but there has always been this feeling amongst places that don't have protons that actually proton centers need men to come with prostate cancer more than the men who have prostate cancer need protons. Last year, there was long-term outcomes presented of a large randomized trial of 400 men who were randomly assigned to get proton radiation or standard Linac-based radiation. This trial was designed to detect differences in quality of life of patients, and there was no patient-reported or physician-reported differences in side effects or quality of life with protons versus photon radiation. There were also no benefits seen in cancer cure rates, although admittedly you probably need more than 400 men in a trial like that to see small differences in cure rates, but there was no signal of that. So there's a lot of talk about Toronto perhaps getting Canada's first proton center. They're really trying to push this forward. I can guarantee you, I don't think you'll see a single man anywhere in Canada treated with protons in Canada. I would not send my dad, even if I had an unlimited amount of money. If I won the lottery one day and my dad was diagnosed with prostate cancer the next day, I would not be sending him for protons. I think that it is a good treatment. They're in a cost neutral setting where there was not an excessive cost of protons. For those of you who don't know, a course of proton radiation can ring you up about $150,000. So in a cost neutral environment, then I would have no issues with it. The issue is that there comes a lot of marketing and the fact that a lot of that is financially driven by cancer centers. My own philosophy. I do have a disclosure with that. I've published in it and I've analyzed the claims on proton cancer or proton centers websites about what they will tell patients on their websites and whether they're backed by evidence. And very often they're not backed by actual evidence.
My question, this machine, so you can go from doing normal MRT to an SBRT, so it can run from a grade, 1 grade to up to 8th grade on this electro. So you can do SBRT and MRT.
Well, technically speaking, this is using IMRT. So SBRT and IMRT reflects how the radiation beam is given. So VMAT, IMRT, they're all very similar things that describe the same thing. And the way the radiation beam is given is actually, it's called step and shoot IMRT, but that's sort of getting into the weeds. We can control the radiation treatment machines to do pretty much anything we want. So in theory, if we had an unlimited amount of time and resources, and let's say my clinics were really, really slow, I could do 20 treatments for a patient on the MR-Linac. There's nothing that prevents me from doing that, other than my sanity and the fact that I have many other things to do that are higher value, I think, from that.
So your sessions are 20 times 3 grades.
3 grades.
Correct.
Yeah.
I know that I'm one of the few people that had spacer put in, which is
Correct.
something that's really only available to people with certain conditions paid for anyway. And it's not available for a lot of people, but in that MRI image you were showing with the gas bubble, I assume that the spacer is kind of pushing that rectal wall where the gas bubble was further away to reduce that risk to the rectal lining. Is that?
Yeah, so in that case, the rectal spacer is acting like that cushion regardless of the gas.
Right.
So when we are designing the plan, you get like a near zero rectal dose with the very high dose area
Right.
with the rectal spacer in place. I could probably talk your head off about rectal spacers. I think that in those who are at elevated risks of long-term toxicity from radiation, those who meet the indications are those who are on chronic heavy-duty anticoagulation, those who have inflammatory bowel disease like ulcerative colitis or Crohn's disease, and those who have bilateral hip replacements, because actually the radiation beam is severely restricted with the bilateral hip replacements. I think the rectal spacers make sense. In the US, about 60% of men getting prostate radiation have a rectal spacer inserted. There are some financial incentives there with that if you start getting into the details of, but the clinical trials do show better long-term bowel patient-reported quality of life. Interestingly, I think that we will have some temporary access to rectal spacers for those who don't meet the criteria, because we are looking at opening a clinical trial here that will probably only be open for about 6 months or so, but the company that makes rectal spacers has a new type of rectal spacer. They're running a randomized comparison between the old one, the one that we currently use versus their new version, and that they will pay for the spacer regardless, and you don't have to have the criteria. So we will probably accrue some patients to that trial. It's not open right now, but you might have some patients asking about that. But that clinical trial will probably be finished in about 6 months or so. So we'll get as many men on it as we can, and then we're sort of back to the status quo.
Now, some will say, I don't need spacers, depending on what they're doing.
Absolutely. It's a great point. And if you look at the average patient who does not meet those criteria from Cancer Care Ontario, the risks of severe rectal toxicity are pretty low. Most clinical trials, they're in the range of about 2 to 3%. Can you get much better than that? I think the counterpoint, though, is that what I think the spacers are helping with are they're making minor issues less common. So I don't think for the average patient, a rectal spacer is going to have a huge difference in the risk of like rectal bleeding or needing a colonoscopy or like really serious damage. Like those are pretty rare issues. But I've now been in Ottawa for 4 years. My patients who are on anticoagulants and I treated 3.5 years ago, are coming back to me with rectal bleeding. And these are known complications. They're things I told my patients they're at an elevated risk for. But I think those are the issues and why Cancer Care Ontario has rolled out the criteria in that way for rectal spacers. But it is a very unique discussion in those, and there are people, and just if anyone is interested, I can talk a lot more about this, but for rectal spacers, I currently don't have a way of putting them in here in Ottawa. So even if you came to me with a nice big fat check, I don't have the location, the wherewithal to put it in, because the hospital can't accept payment for it. And currently we're using the hospital infrastructure. And philosophically, I'm busy enough as it is. You see what's keeping me busy. I don't think there's enough of a benefit for me to open a private clinic and go down to working 4 days a week and spend a day a week putting in rectal spacers. I might drive a slightly nicer car if I do that, but I don't think that's where my expertise is best suited. So practically speaking, if someone who doesn't meet this criteria and they're not eligible for this clinical trial, they actually can go to Toronto and go to the one private clinic in Canada that puts in rectal spacers. When I talk through it for the average patient, I get a lot of people who say, no, I don't think it's really worth it. And that's my philosophy as well.
Yeah, when I was treated in 2017, and you're talking about technology increasing, that was not even, a spacer wasn't even on the market then.
Yeah, it would have been in its infancy then.
2019, 2020 or something like
Right.
that. And it was $2,500 in the States. Now they're charging me 20 grand.
Yeah.
That's nuts.
So, thank you for this, actually, this is very interesting. And I can see actually like two systems, the MRI and the linear accelerator, they are combined into one system.
Correct.
And I would like to have a sense from the operator, like yourself, like, is it easy? Are you killing the cancer better by using this? Because how do you use it? I don't know, like, I'm not in that machine, you know, but
Yeah.
is it easy for you? Are you happy, like, with this? You can really manage to kill?
I'm happy with, from an operator perspective, it's really not all that difficult to use because it's basically the same technology and treatment planning that I would use otherwise. I would say that in terms of cancer killing abilities, I wouldn't tell any of my patients that this is a better treatment than 20 external beam treatments. I don't think the cancer kill rate is going to be higher. There are some of those that will die on the hill that prostate SBRT is better than 20 fractions. We have no clinical trial data to back that up. We might have that clinical trial data when we have 10+ year outcomes of these randomized trials, but as it is right now, I have to counsel my patients in 2025 where there is no data that this treatment is going to be more effective at curing a cancer than 20 treatments. Because some of my patients who have a hip prosthesis, they think, oh, I'm missing out on something that's fantastic. And the honest truth is there might be something to it. And I think if we can get that margin reduction in, there's data that there is something to it. But as it is right now, I think it is an advancement, but I don't think it is a leaps and bounds advancement.
Good question. Go back to that margin reduction. Yeah, the machine you got is you mentioned, not quite as good at that as one of the ones made in the States.
Mm-hmm.
Is that the sort of thing you can fix with a firmware update, or is it?
That's a really good question. So that safety margin is something that our medical physics team has gone through and tested and validated. So shrinking it further is something that requires a lot more work. And it is something that there is interest and discussion about because this talk of technology is what I was talking to our group of physicians about a year ago and saying, my viewpoint then is still somewhat similar now. Like I knew this was going to disrupt my schedule. I thought the big benefit was just patients coming and getting 5 treatments instead of 20. I think there's a huge benefit in that. Time, parking wise, I think there's a huge benefit. But are we really doing something novel if we're not incorporating this margin reduction? And that I think is the real $64,000 question that I will continue to push through. But for now, we're still getting things ramped up and we will see over time how things go.
So this MRI that you are running here, must be operating slightly differently than some of the other ones. I have both hips replaced, but I also have spinal stenosis. And they did an MRI, they get a handle on where it was and how serious it was. And the hip replacements weren't a problem for that.
The issue is not so much in the, like, we can get the images we need for treatment, but the live monitoring images are more distorted, and
Okay.
so it's the live motion monitoring as well as it's the restriction of the beam angles that cause the issues with any hip replacement.
So it's affecting the treatment itself.
Yes.
Okay.
Yeah, so you are right, you can get a diagnostic MRI, but I'm sure if you read the fine text of that MRI report, they will say things like, this is not a perfectly diagnostic MRI because of bilateral hip replacements. We can't use the ABC image set from the multiparametric MRI. All the fancy talk to say that this is still good. It's still better than not doing an MRI, but there are functional limitations there.
Well, it didn't really matter at the end of the day because the neurosurgeon told me, I don't think it's gonna help your back very much if I do surgery, so.
The spinal hardware wouldn't have an impact. It's just the hips are right in the same plane that the radiation beam would have to go in.
What is your outside margin, like 3 millimeter, 2 millimeter?
So what we use for this is we use a 5 millimeter margin and then 3 millimeters posteriorly between the prostate and the rectum.
So, Mark, you're talking about outcomes. So comparing not the two machines, but your different treatment plans, doing ADT and high dose brachy and doing a 20 or a 5 of these two, do you feel that that gives you better outcomes as far as a treatment plan? You know, doing all
There's
three.
a lot in there. So functionally speaking, what we know is that prostate cancer is a type of cancer where the probability of cure is closely related to the dose of radiation we give the cancer. And I cut it out because I knew I was going to talk too long if I left it in there, but the dose of radiation we've used to treat prostate cancer has gone up and up and up over the past 20 years. So the cure rates now are substantially better than 20 years ago. There is no treatment that will get a higher dose of radiation into the prostate than brachytherapy will. So from my point of view, I don't think this treatment will replace brachytherapy, with a very key point for those who are eligible for brachytherapy. And one of the issues with brachytherapy is that I'm very strict about who I offer that to, because with the higher dose of radiation, if I'm not careful, will come a higher probability of peeing issues and peeing side effects. So it is a delicate balance, and that's why there is no one-size-fits-all solution. We have clinical trial data showing that doing brachytherapy, most of the data is as a boost, but still we can make a general assumption. Outcomes are better. And for those who have high-risk prostate cancer and without spread to lymph nodes, just localized within the prostate, by the time you get to 9 years after treatment, the cure rate is 20% higher at 9 years with a high-dose rate brachytherapy boost. So that means 1 in 5 patients that I treat with brachytherapy will be cancer-free at 9 years that wouldn't be otherwise. Well, that also has to do with patient selection. Someone who's 85,
Not so much.
anesthetic risks, more, there is, without a doubt, there is more in the way of short-term peeing toxicity when it comes to brachytherapy boost. It is not a benign procedure. But in someone who is 60, when we're looking at that long-term and knowing the consequences of recurrent prostate cancer, yeah, you know, it's not going to immediately kill you, but going on hormone therapy and ADT. And so I think that for me, this is a replacement of the standard 20 fraction external beam, the 5 fraction SBRT. I still think that for those who are eligible for brachytherapy, it's a good option. I personally do not push brachytherapy on those who I do not think are going to benefit from it. Yeah, so trying to straddle some lines there.
No, I understand.
So you have a question?
Oh,
You specialize in brachytherapy, am I?
I do, yes,
I
but that is a conflict of interest when I talk about brachytherapy.
So, yeah, obviously, so I'm just thinking, I seen another of your colleagues.
Mhm.
That wasn't awful, so I don't know if that was my age, my general situation, or the advancement of the cancer that probably.
There is absolute, like, there is not enough time within a 45 minute to 1 hour consultation where if something is clearly not indicated, like, there's probably about 10 things you could rule out as not option. But in all fairness, our colleagues here in Ottawa will refer to me or the other doctors who do brachytherapy. Of the 8 radiation oncologists who treat prostate cancer here in Ottawa, 5 of us do some form of brachytherapy. So the majority of us are very familiar with it.
Right.
But I do, and I've published some data on this, which radiation oncologist you see in consultation has a huge impact on the probability of receiving brachytherapy. So my philosophy is I'm always happy to see patients. If my colleagues aren't sure, I'm happy to sit down with someone for 45 minutes and talk about pros and cons of brachytherapy. And if I treat everyone that comes to me with a question from my colleagues with brachytherapy, I think that I'm doing a disservice because that means I'm probably missing patients where they're just scared to send on to me. But every patient's circumstances are very unique. And perhaps if I dug into your medical history, I could find reasons why. There's times I can't do brachytherapy. There's times there's medical conditions that preclude putting someone under anesthetic. There are technical things that we have to consider with, like, there's a lot of different things that go into it.
Peter, you had a question too.
Yeah, just a quick one. Under patient selection, you said who is not eligible.
Mhm.
And I assume that there are more eligible than you have the time to choose. So
Not necessarily, no. So my practice is a little bit different because I live out in the west end of Ottawa and I hate driving to the east end of Ottawa. So most of my patients, I see, at least for new patient consultations, over at the Irving Greenberg Cancer Center. So I'm always surprised when I talk through this with patients. You can come to the Queensway and get 20 daily treatments, or you can drive to the general 5 times. Honestly, like when I go through this and I talk about, there might be some technical advances, but still I don't think it's going to have any difference in cure rate. Maybe some data showing some toxicity differences, but I'm not fully committed to that. A lot of patients are keen on the idea of just coming for 5 treatments wherever it is. And from a logistical point of view, we are not at a point that we are at a treatment rationing where we are not offering this to certain groups of patients. I will offer both, see what their preferences are. We are at a point, though, that we are limited in the number of patients we can treat per day, and there is a waiting list for this, which is unusual for radiation in general. In general, Cancer Care Ontario funds cancer centers such that the time between when a patient is ready for radiation and their first treatment should be less than 2 weeks. So there's some nuances there, like a spacer insertion. Well, that we have to coordinate OR time for, so the clock doesn't start right when I say we need a spacer insertion. But for an MR-Linac, we're not meeting that criteria because the wait times are almost always more than 2 weeks. What I heard when I was there today is I think the next open new start for the MR-Linac is a time in like early November, so closer to 6 weeks. We keep increasing that, and then there's like I just heard that the machine is closed down over the Christmas break, so then November, so there will come an issue with wait times with this. I have no doubt about it. How we will deal with that, I'm lucky we pay hospital administrators so much money to tell me what to do. So, and we'll figure it out as to. Right now, we're not saying, no, you cannot have this. Anyone who wants this, and we think that this is a good option for, welcome to have this as a treatment.
Thank you very much. Thank you very much, Mark, for coming out to see us. And we know you're very busy. You got a small family. We really appreciate that you're here to give us a tremendous talk.
Yes.
Thank you very much.